Well, it's just 9 o'clock now, so though I know people are still joining, I'm going to go ahead and get us started because we have a lot to cover today. So hello, everyone. Good morning. I'm Kate Myers, Senior Program Officer at the California Healthcare Foundation, and really pleased to welcome back those of you who were able to join us for our sessions yesterday morning, and welcome to any newcomers. This is day 2, the final day of our Driving Improvement in Medi-Cal Palliative Care session and statewide virtual convening. Really happy to have you all here today. So yesterday, just to quickly recap, we spent some time learning about and discussing how implementation of palliative care in Medi-Cal is going across the state, reviewing information that many of you on Zoom provided through our surveys, including thinking about and discussing areas where we've seen growth and improvement, and areas where there are remaining challenges and where plans and providers have identified priorities moving forward. We also spent some time yesterday thinking more deeply about the role of virtual care in our Medi-Cal palliative care services as we begin to hopefully emerge from the COVID-19 pandemic, and focused on providing a framework of considerations and decision points for plans and providers around virtual care. That framework document was also sent out yesterday after the meeting to yesterday's registrants. Today, we're excited to dive into some more of the nuts and bolts types of issues around program implementation. We'll start by hearing from 2 plans and 2 provider organizations from California about innovations that they have found to be helpful for them to focus on improving quality and impact of their palliative care services in different ways. We're really excited about those sessions offering some quite practical and specific ideas and tools that some of our community members are using. And then the second part of our morning will be spent examining some of the variations we're seeing in program implementation for Medi-Cal palliative care services among different plan and provider partners. And the types of variations we'll talk about include variation around approaches to eligibility, approaches to the services being provided, the staffing and care model being used, the payment models, and approaches to measurement and reporting. We'll spend some time talking about how you all are thinking about potential ways you might modify your approaches to any of those issues as well. So we're excited to spend the day diving into some practical and hopefully really helpful concepts with you today. We'll quickly move to a housekeeping slide, and then we'll get going with our first session. So I won't read through all of these. This is information you received by email, and I'll, in a moment, put it into the chat as well once we're past the slide. But just the most important things I'd say are, for those of you who are on the phone for your audio, please link your phone audio to your Zoom online profile. That just means you appear as one participant rather than as 2, and you wind up in one breakout room with both your audio and video later in the morning. And secondly, we'd love it if everyone could change their display name to show their full name and their organization. The information on how to do that is here. I'll also put it in the chat in a moment, but this will help us know who's here and will help us in our breakout sessions later in the day as well. And because it's always a popular question, yes, slides and recordings from each of the main sessions, though not breakout sessions, will be available on the CHCF website probably within a week or 2. So we will get that out to you. With that, I'm going to hand it over to Monique Parrish, who many of you know is a consultant to CHCF on a variety of projects related to palliative care. And Monique will be facilitating our first session.
Great. Thank you so much, Kate, and good morning, everybody. We are just thrilled to have you back again for day 2. And I'm going to pick up where Kate was sort of sharing about yesterday's learnings and really showcasing the positive growth trend in both referrals and enrollment, and also in how both plans and providers are measuring both impact and quality. And we want to lean in on that with showcasing these innovations this morning. Just a quick little nod to all of the teams of both health plans and providers organizations that submitted innovations. We've received over a dozen, and this is a chance for us to look under the hood to see how this positive growth is really materializing. Just a couple of words before we get started. I want to share with you that each presenter has 20 minutes to present through a PowerPoint presentation their innovation, and they're going to fold in about 5, 6, 7 minutes of Q&A period. So during each presentation, a total of 20 minutes per presenter, they will include the Q&A within that 20-minute period. So please include any questions you have in the chat box. We'll also have a moment for you as they're going through it for you to go ahead and add those in. I'll be facilitating that Q&A, and then we'll move on to the next presenter. Just a quick note, in between our 4 presentations, we have a little bit of a micro break, a reflection exercise, and I'll guide you through that. So with that, I'd like to introduce our first presenter, Dr. Eve Makoff. And Dr. Makoff is the Medical Director of Palliative Care at MedZed. And from the bios, you all had a chance to see that Dr. Makoff has a very diverse medical background. And prior to coming to her role at MedZed, she had created a system-wide palliative care program at Torrance Memorial. And with that, let me pass the baton to Dr. Makoff. Thank you.
Thanks, Monique. Nice to be here, everybody. I'm going to be off camera, I think, for this portion. So you can go ahead and get started with the slides. So this slide is really just an overview of MedZed in general so that you can distinguish between the different programs that we have. We have our palliative program, which has an active panel size of about 130. Obviously, we have the interdisciplinary team. We have 24/7 coverage. We hold on to our patients until they're ready for hospice. And we do basically a visit a week with our palliative patients. Our second program is our complex primary care program. The panel size is about 2,500. And the difference between this and the palliative program is that there are maybe 1 to 2 in-home visits with nurses in the home, and I'll talk more about the model in general in a second, but 1 to 2 visits as opposed to 4 visits, and we don't regularly have social workers involved with that program. And our Health Homes program is really a socially focused program and also an outreach program. It's one of the ways by which we reach people who are in really hard to reach places. You can go on to the next slide. So this is an overview of our palliative program. So our program was launched in 2018. We've served 334 unique Medi-Cal members across the state, and we see patients as far apart as Chico, the Butte County area, Fresno, San Francisco, and Los Angeles. So we have a very broad geography that we're serving these patients. It's obviously an integrated model. We focus on social, emotional, spiritual, and other aspects of quality of life. We have 24/7 availability. We offer bereavement services. Our chaplain actually reaches out to families after someone passes away, and we send out memory boxes as well as cards and books to the patients. We have 2 health plan partners, and our payment model is per member per month. Next. So what is our innovation? I would just say in general, our innovation is that we meet patients where they are. We meet them where they are geographically, and we meet them where they are in their healthcare journey. And we have the ability, in addition to getting the regular referrals from our health plan partners, we can transition patients between our programs. If we have a patient in our House Calls Complex Care program and it looks like they're progressing along in their illness, they're having more needs, they're feeling having more challenges with quality of life, the provider who's seeing them in the House Calls program might decide that the patient might be better suited to our palliative program. Sometimes patients transition to a different provider within our organization, and sometimes they don't. It just depends on the relationship, and it depends on the comfort level of the provider. When they are able to transition over to our palliative program, it's just a matter of layering on resources for what's necessary for that patient in that moment. If they're needing more social work help, if they're needing a chaplain to talk to, if they need more case management, then that might be somebody obviously with serious illness who's more appropriate in our palliative care program. You can go on to the next slide. So what is the challenge? Why did we come up with this model? Well, for many of our patients, the difficult circumstances of their lives have them experiencing frequent gaps in their care. Okay, constant care transitions are pretty much the norm in our population. And this leads not only to decreased patient and family satisfaction, but also those sort of voltage drops in care where things get missed. The quality is down. Now, our patients, if they are able to transition from our house calls to our palliative program, they basically don't have to transition again, except when they're ready for hospice. And also, because a lot of patients in our population are not that familiar with palliative care, obviously our house call providers are also very well versed in what palliative care is and can start that conversation earlier. And we can reach people geographically because we do have our community health navigators who find people in hard to reach places. And our nurses are stationed where the patients are. We can reach people in geographic places where sometimes they're missed. You can go on to the next slide. So again, our contribution, meeting patients where they are in their healthcare and in their geography. We identify patients, engage them through our house calls program. We layer on our palliative staff and services, and we are able to connect through remote resources. So what we have is an LVN who goes into the home and who creates a strong bond with the patient. And through our telehealth platform, the LVN can then bring a provider, a doctor, a nurse, a practitioner, a PA, a social worker, a chaplain, a case manager into the visit through telehealth. So this hybrid model really allows us to layer on whatever types of support the patient needs. You can go on to the next one. So who are our partners in this endeavor? Well, we have our external partners, and that's our relationships with the health plans. We have monthly, at least IDT rounds with the plan and our palliative program. We have weekly calls with our health plans to discuss new and pending referrals. We have ongoing email exchange between the case managers on both sides regarding patient status and care needs. And then we monitor their utilization. And if we have questions, we reach out to the health plan for further information. We also have been able to access many shared electronic health records, so we can actually find out what's going on with our patients clinically, even up in Fresno. In terms of internal, we have basically an ongoing dialogue about all of our patients. We have weekly internal meetings, but we have a daily team chat that is very active with all of our palliative team members on that chat. I also have a chat with all of our palliative nurses. We do have a specialized team of nurses who we do regular training with. And again, we can access medical records in many of our markets, and we do have 24/7 availability for urgent issues. You can move forward. So what's the surprise? It's been amazing. I mean, I've been here for a year to watch the relationships that we're able to develop even within a telehealth environment. Now, number one, the relationship is formed with our nurses who are there in the communities of our patients. They know the community, they know the patients. Sometimes our nurses see the patients out in the world, but there are some very specific things that we've been able to accomplish, of which I'm really, really proud. And one was our chaplain. We had a patient who was actually very resistant to going on hospice. And we sort of had to go back and forth with him a lot. He's the only patient at MedSed I saw in person because I felt he didn't live that far away from me. So the nurse and I went to his home, but that wasn't even enough for him. He said that the only thing that was going to allow him to be more at peace was if he could have a baptism. So at an appointed time, our nurse went to his home and our chaplain got on the telehealth platform and was able to baptize him, and he did end up going on hospice. We have additionally helped multiple patients get into drug rehabilitation. Our social worker actually put someone in his car and drove him to rehab, and he might still be there. This is not something that we normally would do or advocate doing, but we did have one patient whose sister is an RN who was caring for him, and they had very strong feelings about not putting him on hospice. In fact, I have to agree that she did at least as good a job as any hospice might have done. So we were able to facilitate a comfortable death at home. He actually didn't need any pain medication, but our nurse stayed with the sister until she had someone else arrive to be with her through that night. We've also conducted same-day appointments for patients in distress or to avoid unnecessary ER visits. And we've found some very, very difficult to engage and locate homeless patients. And we know that our patients and families are very, very satisfied with our care. I know with the patient satisfaction surveys, we are among those who don't get very many responses, but we get the responses. I have texts, our chaplain has texts. We've all been told verbally how much we contribute to their quality of life. So I know that we all have to work on better ways to get data regarding patient satisfaction, but we've had it sort of in real time. I think, yeah, so the takeaway, again, I mean, meet them where they are. We reach patients as they're declining. We decide what services and what team members are going to best help them, reach their healthcare goals and live out whatever is left of their life with quality. We're able to provide a warm handoff if we do have to change any team members. We are able with our CHNs and our nurses to locate difficult to find people. And we also have our telehealth platform so that we can bring everybody into the room, even if we're remote. I think that's it.
Okay, Dr. Makoff, thank you so much. We've got a few questions coming in, and a number of people are really interested in this hybrid model. So the first question that came in is, tell us a little bit more about how you address physical symptom management. Imagining that must be a part of your service, but would you tell us a little bit more about that?
Sure. So yeah, obviously we do a full comprehensive evaluation of our patients. We do an ESAS multiple times with our patients and assessing how they're doing physically, emotionally, spiritually. We also assess their functional status. It's different with each patient what role we play in terms of medicating them, because for example, if they have cancer and they have an oncologist and often they're nurse practitioners working with them, we feel more comfortable that they're seeing them regularly in person, that they would prescribe controlled substances, opioids. Sometimes we do have to fill that role. We have some markets where it's much harder for people to get in to see specialists, or maybe they don't exist, like in Butte County. Ever since the Paradise Fire, there's a real lack of resources for patients. Some can't even find a PCP. So we have had to extend what we do for those patients, but we really try to maintain our palliative care role. And of course, I mean, symptom management is part of palliative care, but it's a little bit different in my mind if we're on telehealth versus in person.
Sure.
We certainly treat nausea and cough and, we'll treat constipation and things like that. It's more in the range of controlled substances that we have a little more pause, but there's no rule.
Well, maybe as an extension to this, there's a question about really moving into that primary team. So talk a little bit more about that collaboration and maybe handoff or sharing of some of those functions and responsibilities in managing the patient.
You mean their PCP in the community?
Correct. It's with the primary team. Yes, please.
Depending on the market, the PCPs are more or less involved or able to be contacted. Certainly there have been times, like if I had a patient with cancer and I couldn't get the medical records, like we don't have all of the EHRs available to us, couldn't get the records. The patient didn't seem to understand the status of their disease. So I called the oncologist. Okay. And then other times I have patients with, cardiac devices. I've reached out to the cardiologist. I've had PCPs reach out to me at times, which I'm thrilled when they do that. But often what they want is for us to take over care. And so I have to educate them that we are palliative care and we are remote. So there's not as much. I mean, there's certain markets where we do have more interaction than others.
Well, and I'm going to shift here a little bit. There's a question about your access to EHR. You had mentioned that you have access to a number of EHRs and you're able to work with those systems. So this question would love to hear a little bit more about that process of getting access to those different EHR systems and how do you kind of make that happen, get it up and running?
Yeah, I would have to defer to the administrators in our company to know how, but it hasn't been, it hasn't been that difficult. Sometimes it takes some time, but we do have access to Epic in certain markets and to other, there is the Care Everywhere feature also in Epic. So sometimes if you're on one, you can see things that are happening in others. We don't have access to as many EHRs as we would like, but it has been pretty critical in some situations.
Well, maybe staying with that, there was a question about the specific telehealth system that you're using. Do you mind sharing a little bit more about that?
So we use Teams. My boss, Neil Solomon, is on this call, and he may know more about getting access to EHRs. But we use Teams to connect to patients. The nurses go into the home and they put the patient on Teams with video, and then they link in the clinician.
Great. And maybe similarly, this is a little bit about billing, and you may or may not know this, but do you have any information about how you bill for kind of the complex care panel? I believe it's a code 2500. And if you're aware of that, great. If that's not something you're aware of, we can.
Yeah, I don't know. I don't know the answer to that. Okay,
great. And we do have, Neil has shared that he's one of the administrators at MedSed, and we're able to get Epic access at some point at some of the largest hospitals with which we collaborate.
Monique,
yes, please.
Kate, just one correction. I think the question, there are two questions that have to do with how you get paid for things. And I think the question about complex care was not a code, but it was referring to the 2,500 complex care patients that you have.
Okay.
And how your program gets paid for those. And so I imagine that's a health plan contract sort of response, as opposed to fee for service. But if you're able to address.
Thank you.
Yeah. No, we get paid per member per month. We don't do fee for service.
Okay. There was just a comment that I think we should enjoy here. And again, if there's any additional comments or questions, feel free. We've got a few more minutes. And this is really the recognition that you're not transitioning your members in and out, back and forth between the hospice after they join your palliative care program. So they wanted to know a little bit more about the criteria for palliative care for your members that you're serving.
I'm not sure if I understood the question.
So it says, I want to make sure that I understand. If there's any, it's amazing that members don't have a transition other than to hospice after they join your palliative care program. What's your criteria for palliative care? And I'm imagining it's similar to some of the SB 1004 criteria, but if you can chat a little bit more about that.
Yeah, I mean, we get our referrals from the health plans, right? So they're the ones who approve patients for palliative care, and it's in line with SB 1004 regulations. But there may be patients outside of that we talk to the health plan about and get approved for our services.
Nice. Okay. We have one more question here. Let's see, we've got a little bit more time. During the visits in which you have a nurse at the home and a nurse practitioner via telehealth, how do you bill for those visits? Do you only bill for the nurse practitioner visit?
We don't bill fee for service. It's all included.
Back to the per member per month. Okay.
So our contract specifies how many visits, how frequently we see the patients. And within that, we just schedule according to contract.
Great. I'm wondering if you could you talked a little bit about your internal and external partners, and you're talking about social determinants of health. Can you talk a little bit about your outreach? Of course, you shared the example of dropping somebody off at rehabilitation, but talk a little bit about extending that extra layer of support with some of those external social service providers. Are you able to do that? Especially thinking about your community health navigators.
Mm-hmm. You mean connecting to resources?
Resources in the community.
Yeah. Well, in our palliative program, the social worker really takes the lead in terms of that, but we do have CHNs on the ground. So in all of our markets, if there was something that specifically we needed somebody on the ground, our social workers and our CHNs in our other markets help with things like completing IHSS and disability type paperwork, helping find housing, food resources, anything that they need, we try to get to the bottom of it.
So it's really extending outwards. And last question, how's it gone having a health homes program and palliative care? Can you talk a little bit? You got about a minute. Members are confused, or is really that collaboration pretty smooth with that sort of collaboration there between those two programs?
So our Health Homes program is a non-clinical program. It's a social needs only program. So some of our CHNs are only addressing social needs, but some of our CHNs are integrated into our clinical teams. So it just depends where they are, because there are some areas where we don't have nurses and we don't have providers. So, our goal obviously is to expand all of those, but they are a couple of different ways that we use CHNs.
And with that, Dr. Meekhoff, we're going to wrap up here. Thank you so much. That was really interesting. And again, for all of you who are adding questions, thank you for your questions. We are keeping those in a log. Next, I'd like to introduce Blanca Martinez. And Blanca is the Director of Case Management for Molina Healthcare of California. In addition to her Master of Social Work, Blanca is credentialed as a certified case manager by the Commission for Case Manager Certification. And you will note from her bio that she has deep experience in working both with health plans and working in a variety of healthcare settings. So Blanca, we look forward to your presentation.
Thank you, Monique. And thank you really for this opportunity to be able to learn from each other. I look forward to sharing our innovations, and I hope that you find them helpful as you continue to enhance your palliative care programs. So in this slide, it really just covers Molina. We were established in 1985. We operate in 7 different counties, as you can see in the map down there of California. And we cover beneficiaries with Medi-Cal, Marketplace, Medicare, and CalMedi Connect. We are contracted with 16 palliative care providers across our regions, or the 7 counties. Our primary payment mechanism with our contractor vendors includes a monthly case rate, but then also an additional fee-for-service add-on. So within the monthly case rate, that includes advanced care planning. It includes a minimum of 4 touches a month, with 1 being face-to-face. And it also includes the care coordination activities and the care team interventions or support. The fee-for-service, that's billed separately apart from the monthly case rate. So let's say that the vendor's physician or nurse practitioner needs to provide an intervention, see the member, consult with the member. The palliative care vendor is able to bill that separately, and so it's not part of the case rate, and that makes up our contracts with each of our contracted providers. And for the fee-for-service add-on, they don't need to ask for authorization. It's really clinically based, and at the end of the month, they just bill us for those services. Next slide, please. So today I'll be covering 2 different tools. Our palliative care tracker, which is basically an Excel spreadsheet that we created. It was homegrown. And then also the palliative care dashboard. These two tools have allowed us to be able to track our referrals, and have also allowed us to develop strategies and interventions to continue to grow the program. And, one of the things that we wanted to do with the inception of the benefit is, how do we enhance this program without it just, because we understood the benefits that it would have and the impact that it would have on our beneficiaries. We wanted to make sure that we sustained the program, that we allowed it to grow and mature. And so these tools have really allowed us to do that. And I'll be reviewing what these tools look like and the components within these tools during the next few slides. Next slide, please. So first, I'm going to focus on the palliative care tracker. Our case management staff who maintain a caseload as part of the palliative care program, and our palliative care leads are responsible for updating this Excel file. So it lives basically in a shared area, and the staff when they have the ability, are able to update it and maintain it. The palliative care leads also hold responsibility for the integrity of the data. And I'll share a little bit why that's important. So when you look at the Excel spreadsheet, these are some of the data elements you will find in it. You'll find the referral date, the source. Is it an internal referral? Is it an external referral? You'll find also member demographics, like the member's age, gender, the diagnoses, what led the member to be referred to the program. And that piece has really allowed us to, has influenced and allowed us to have the necessary information to expand the benefit to not just those four, to expand outside of the 4 criteria under the Senate bill. So this information has been quite helpful in that way. Additionally, if a member ends up not enrolling into the program, but they met criteria, that is tracked. If a member declines the program, we're also housing the reason why, because then that ends up allowing us to see if perhaps we need to do maybe more training, or if we need to leverage our palliative care vendors to help train our staff on how to present the benefit. Also, we house the POLS and advanced directive information along with any disenrollment outcomes or and even the date. So for example, if the member ends up transitioning to hospice, we capture the date and that they actually also transition to hospice. And I'm seeing the chats come in, sorry, so I'm tempted to want to answer as I go, Monique, so I'll try not to.
Yeah, just go ahead. You're doing great. And we'll do it.
Okay, awesome. And so, we have been able to use this data, like I've mentioned so far, in many ways. It's, when we first developed this homegrown Excel file, we thought, okay, we're going to develop it out of the need to provide, data to our regulator. And then we realized, oh no, this is like a pot of gold. We need to maximize the information that we have. And so we started adding more pieces to it to really, like I said earlier, to ensure that we're growing the program and identifying the right members and at the right time, and really ensuring that we maximize the information that we have. So we also track the referral source for our annual department performance metrics. So all of our case management team, which includes our transitions of care staff and our community health workers, have annual goals that their supervisor helps them achieve, and it's tied to their performance at the end of the year. So one of the goals we've adopted across all of case management is a goal around increasing referrals. And so we're able to track, for example, Kate. If Kate is, if that's her goal, right, to help increase the number of referrals, then we're able to produce to Kate and her supervisor how many referrals she has submitted during a period of time or during the whole year. We also provide bi-weekly to monthly updates to our internal stakeholders so they understand where we stand with our goal across even by region. So we can see in LA County versus San Diego County, how are we trending with the referrals and also the enrollment. And again, like I mentioned earlier, we've been able to develop strategies and interventions. One example would be we realized that we were not receiving a lot of referrals in a specific region. And so we were able to we were able to meet with certain stakeholders to help figure out, what are the barriers? Why are we seeing a low trend in referrals in comparison to other regions? And then develop strategies to help increase those referrals. Lastly, the information that we house in the Excel tracker is pulled into what we call our palliative care dashboard or report. On top of that, we pull in claims information. So I know I saw a chat earlier about, ethnicity, so we're able to pull in any other information as well into this palliative care dashboard. Next slide, please. So we have 5 components to the palliative care dashboard, and I'm going to go ahead and go through all of them, and they're outlined here. It starts with the summary through the program highlights. Next slide, please. So in the summary page, what you will see is from my left to right, the total members to the gender breakdown. And also, if you want to see, well, currently, how many do we currently have enrolled, or during a certain time frame, you want to see how many we enrolled, then the dashboard will provide you with that information. In the 4 quadrants here, you can see that we're analyzing a few things. We're looking at utilization, for example. So of the members that are enrolled in the program, that's your black middle bar. How are we doing with utilization in relation to in emergency room and inpatient visits? And then compare it to once the member discharges, let's say goes on to hospice, do we see a decrease in that? The teal represents those members that were referred, met criteria per the Senate bill, but ended up not enrolling into the palliative care program because, let's say, they declined enrollment. So we want to be able to study and compare those as well to see the benefits of enrolling in the program, but also once they enroll and they transition onto hospice, if we're seeing a decline in utilization, that tells us that the members' quality of life, that they're having quality of life because they're not going to the emergency room, they're not going to the hospital, they're actually receiving care at home, and their social support, along with the support of the hospital, of the palliative care, and then now hospice vendor, is really helping them. So we're tracking that as well, and it gives us really good inside information that we can use with our internal stakeholders as well. Next slide, please. So this just shows you the filtering capabilities. There's a filter icon to my right on the top. And if you click that, it allows you to filter. So if you're interested in seeing, okay, I want to know of those that enrolled in palliative care and then transition onto hospice, what was the average months that they were enrolled in palliative care before they went on to hospice? Or let's say that you're interested in seeing ER trends or inpatient trends for those with liver disease versus those with cancer. So there's a lot of ways you can kind of play with this and get the information that you're interested in looking for. Next slide, please. So the member details tab of the dashboard, remember there's 5 components to the dashboard. So here you can see the entire aggregated information of our members, their demographics, their enrollment, disenrollment trends. It flags that they went on to hospice. It flags how many months they were enrolled in palliative care. And then also the total cost. And it also shows who the vendor is that was caring for that member. Next slide, please. So here is our cost trend. Obviously, it's important to understand how we're doing with cost. And then here you can see in the black bar on the cost trend box under program highlights on the right-hand side, you can see once they enrolled in the program, their cost has gone down. You can actually see that. And please keep in mind, I had to de-identify information. So I'm just kind of going over the capabilities of the dashboard, but, in case you were worried about, PHI violations, I did de-identify the information. So, but this really shows you, are the interventions of the palliative care vendors helpful, right? And obviously we can see they are. There are some spikes, and if you click on the teal bars when there's a spike, what ends up happening is it populates who made up that total cost. So you can see like, oh, that was Blanca when she went in for, X, Y, and Z. And then it'll show all the dates of service related to that. So we've been able to look at this and study, who ended up kind of costing us more and why, and were we aware of that? Were we working towards that? Is there an opportunity there to support our members? And for the most part, because we are working with our palliative care vendors throughout the month and meeting with them monthly, we're pretty aware of, these scenarios already. Next slide, please. So this is the vendor comparison. And we love this because even though it's not apples to apples, because each vendor across our regions, their enrollment looks differently, we can still see a lot of information that's helpful to us. So we can see, if we focus on the 4 quadrants there, the average cost per member per month by vendor. We can also see utilization by vendor, but then again, also once they're in the program and once discharged. So you can kind of see that behavior and those trends changing. Am I out of time?
Yeah, Blanca, I was just thinking, I'm interacting here, looking at all of these great questions. This is a tremendous set of tools. We do have a couple of questions, so I'm reluctant to cut you off, but we want to make sure that we slip a few of these in. I want to assure everybody that Blanca has shared an empty version of the spreadsheet that will be available to all. Just a couple of quick questions, and then maybe if we've got a minute, we can flip through the rest. This just came in. Can you remind the group the program you use for your dashboard?
Yes, it's a BI, it's a Microsoft Power BI tool. We worked with analytics, the Molina Analytics team to pull into this BI report tool the information from the Excel file. And then they also pull in claims information. So I saw a question around pharmacy. Yeah, it pulls in pharmacy. And if we move to the next slide.
Okay, go ahead.
Yeah, so it does pull in, and I think it was in one of the slides, like all the different points from claims that it pulls in. So it's pharmacy, fee for service. Because we are heavily delegated in some of our regions with the medical groups and IPAs and MSOs, there is a 90-day lag with the claims. So just kind of keeping that in mind.
And can you talk a little bit, as you're maybe wrapping up here too, talk a little bit about members who've declined and how you're really tracking that, and what is your response to that? You get all this rich data. So tell us about that a little bit, your process.
Yeah, no, absolutely. And, we're able to see how many referrals come in, and of those, how many end up enrolling. And so then if we have 1,000, individuals that have been referred, but only, let's say 5 enroll, then we're able to look at the reasons behind that. So if they're declining because, lately they've been declining because of COVID, honestly. They're just afraid to have people come in. They're not really interested in the telehealth, And so we're able to work with the reasons they're declining and figure out strategies, and maybe partner with our palliative care vendors to help us figure out how to use motivational interviewing to engage our members.
I'm wondering, we've got another 2 minutes out. You have some terrific slides. You've gone through and showcased all of the highlights from the dashboard, and you have some concluding slides about the challenge and need addressed, your partners, and then sort of this final slide. Could we move to, let's say, starting with challenge, need addressed? Perfect. And we could just wrap up there with those next 3 slides.
And
thank you.
I covered this kind of in the beginning, so I do apologize. I kind of wanted to show, we really wanted to sustain and develop our palliative care program. We wanted members to access care. So we knew we needed data to demonstrate what's not working. Why are they declining? Why are we not receiving referrals internally or externally across the various regions? So I think I've covered this already, along with probably the next few slides. I try to cover them all as we were speaking, So
how about your final one then? This is terrific.
So, and I think I've covered how we've used this, right? We've identified program barriers, and we've been able to implement changes. We were able to compare by region, by gender, by week to week, how we're trending with referrals. And overall, if the programs that the contracted vendors we're working with, if we're seeing that the members are making progress, and they are. And so I'm thankful for all of our contracted providers that are probably on the line. Thank you.
This is just perfect. Again, another terrific innovation. Blanca, thank you so much. We are now going to do a micro break. And what we'd like you to do during this micro break, a brief reflection, take 5 minutes, and then we'll introduce our next set of innovation presenters. But think about these innovations, Dr. Eve Makoff's innovation with her hybrid program, these terrific tracking and dashboard tools that Blanca showed. How might you use these? Again, reminding everybody that slides, a recording will be made available. And we are very fortunate that, again, Blanca has shared an empty version of her spreadsheet. So we will return at 9:50. So take the next 5 minutes, please. Think about how you might use that. If you have any questions, go ahead and put those in the chat box. Again, thank you to our 2 presenters. We'll be back in 5 minutes. Thank you. Join in about a minute, everybody. Again, if anything inspired you and you want us to kind of log it in, this is a great time to put that in the chat box from these terrific innovations, anything that inspired you. Okay, it's 9:50, everybody. What I'd like to do again is just extend a terrific thanks to our first 2 presenters, and with great delight introduce the next set of our enhancing Medi-Cal Palliative Care through innovation. And we're going to start with LA Healthcare. And we have 2 presenters with LA Healthcare. Dr. Susan Stone is the Medical Director of Care Management Services at LA Care Health Plan. She is double boarded in emergency medicine and hospice and palliative medicine, and has been at the forefront of providing both direct patient care and medical leadership in both of these areas throughout her career. Her colleague, Lerva Sanchez, is the Managed Long-Term Services and Supports Palliative Care Nurse Specialist at LA Care Health Plan. And Lerva comes to her position, again, another reflection of all of these folks with great depth of experience and great clinical skills and thoughtfulness to boot. And she comes to her position with clinical experience in public health, disease management, case management, and really focusing on patients with both chronic and highly complex conditions, pediatric and adult. And with that, I'm going to pass the baton to Dr. Susan Stone and Lerva Sanchez. And Susan, you're on camera, and I believe your colleague, Lerva, will be off camera, right?
Yes.
Terrific. Go ahead, please.
Hello, everybody. We are so happy to be here today, and we appreciate the support from California Healthcare Foundation and the Coalition for Compassionate Care for having this meeting today to learn from each other. And I've already picked up a lot of tips from all of you. Who are we? LA Health, already choking here. We are a very large public health plan, probably one of the biggest in the country, and we serve over 2 million Angelinos. We provide coverage to some of the most vulnerable people in the population, and they have complex medical needs and social needs. We're mission driven, and within that fabric of our mission, we have found that palliative care has been an amazing fit in attaining our goals in providing equitable, high quality care through our population. And we are very focused on a population health agenda that marries population health and palliative care, providing the right care to the right patients at the right time. And I may add a 4th paddle to that triple aim, at the right place, because that can be a complex issue in this population. And we serve our population through our MLTSS program, which took over palliative care in 2018 and has done wonders with it. We have a team. Lerva Sanchez, who you'll meet, is our basically master of all trades and our nurse coordinator for the program, but we have a much larger team that supports this effort. So Lurva would like to present our first innovation.
She's having technical difficulties. So Dr. Stone, do you mind going ahead? Thank you.
I'll be happy to go ahead. So finding the right provider in our population isn't as straightforward sometimes as you might expect. As I said, we serve a diverse population. We have many languages. We have a very large spread out area within Los Angeles County that goes from the ocean to the mountains and almost to the desert. So it's a pretty widespread area. We have members with significant social needs. We have members on the street. We have members in nursing homes. We have members everywhere. So finding that right fit to provide this high quality care took some work. And we have to make sure that our care is culturally appropriate and that not every vendor is a good fit necessarily. So what happened is we decided that to address these issues and the importance of equity in our population, a patient identification matching tool was developed. The challenge that needed to be addressed was, as I said, we have to follow the mission of our health plan, and we know we have a lot of cultural diversity within the health plan and without, which is very helpful. And we have been providing this type of care in all other aspects of our programs for over 20 years. So it was very important that our palliative care program mirrored that rich cultural diversity of our own staff, and it underscored the importance of us of putting together the right relationship with the vendor, with a particular patient and their family. So we developed a member matching tool. It looks a little weird here, but what we did is, does that look right, Monique? Anyways, I'll explain.
Oh, sorry, Susan, I'm interacting with Lurva, my apologies. This is an animated slide that Lurva was going to show, so it will move through the tool. I think that's one of the issues here.
On the call?
Hello, yes.
There she is.
I'm so sorry.
Okay, we got her on. Okay, great. Thank you, Lurva.
Okay.
Do you want to take it from here?
Okay. Yeah, I had to log off and then log back on.
Okay.
So I'm not sure how far Dr. Stone got.
I am at member matching triage tool, the animated version, if you could take it from there.
Okay, got it. So this tool really was born out of an experience that I had early on with my involvement in the program, where we had a Korean-speaking member who was very adamant about only seeing a provider who was Korean speaking. He did not want to have a language line involved. And so I found myself on the phone calling each of our providers that day. And as you can imagine, I was very frustrated, but successful. I found one and just thought, there has to be a better way. And so we decided to create a template to make an inventory of information about our providers. And here we have the template, very branded for LA Care, but it has 5 different sections. And if you can go ahead and move forward. So the first section is a basic contact sheet with contacts and roles for different staff within the organization. And if we could go to the next slide, please. The next tab is the language. It includes all of our threshold languages as well as American Sign Language, and asks whether the organization has access to a language line, and they can also indicate any additional languages that their staff members speak. And so they would indicate yes or no for each, or for the optional, they can just fill in the blank. And we included very clear instructions there so that everyone knew exactly how to fill it out. Next tab, please. This is the population and services section. It includes things such as whether the provider can service unsheltered members, if they offer respite care, if they utilize volunteers, offer telehealth, very important, whether they prescribe or defer to the primary care provider, and also any additional unique things to their organization that they can fill out here. And next slide, please. Service area is extremely important because LA County is so expansive. And so we asked our providers, we provided them actually with a list of all of the zip codes in our coverage area. And they were to fill it out by indicating which were non-service areas. And we also asked them to provide a list of contracted skilled nursing facilities. And then with all of this information that we took from each of our providers, the actual triage tool is a summary of all the information that we collected from our providers. And we have a few examples here of what that looks like. When you aggregate all the information, here each of the providers is on the top. You can very easily see, if you have a referral, the member speaks Farsi, you can see here that 3 of the providers are able to service that. And then next slide, please. And then you would move on to also pinpointing maybe which one of those 3 providers actually cover the service area where the member resides. And this was also really helpful for us to see maybe where there's areas of opportunity if we are interviewing new providers where we may need to fill in some gaps. And I would recommend that this be updated at least annually, but probably 6 months would be ideal. Or if you notice that any referrals are frequently being bounced back for whatever reason, like staffing issues from a provider, then I would return the template, their specific template, and ask them to update it. If they've had staff turnaround recently, then we would want to make sure that we have the most updated information. And with that, I will go ahead and hand it back to Dr. Stone.
Hello again. So palliative care is clearly improving quality of life for everyone involved. But how do we measure quality? And there's been work around how to measure quality in palliative care. We know that we want our providers to meet all the aspects of palliative care possible, and that if they can't, we need to work with them to get them up to speed. And so we decided, because our palliative care program is part of our population health agenda and part of our quality improvement program, that we needed to provide an audit tool. And this was really helpful to level set with the palliative care providers, ensuring that they're meeting not only the expected standards in the all plan letter for SB 1004, but even deeper. And so this allowed us to kind of give them a grade and see how they were doing, since we're entrusting them with our vulnerable members. And the results are shared with them over time. So the audit tool was developed with looking at the National Consensus Project Domains of Care. Some of the portions of the audit tool included outcomes and process measures, along with the physical and social aspects of care. And we didn't want to get too lost in structure and process, but it is important to make sure providers are delivering what they need to be providing. And the standards are a little bit more expansive for our pediatric program because they get extra services. So what we do is, on a quarterly basis, we take a stack of their charting and we go from one end to the other, and we look to make sure they're meeting criteria that we have set forth. And what this does is it generates for us, a grading system, a report card per se. And this has been very helpful. What is the next slide, please? Oh, go back, sorry. So this has been really helpful because, as you know, many of you out there, there are some vendors you're not so sure about. And if there's a huge outlier, we need to address it. And if that provider cannot meet our standards, then we need to not use them within our health plan. We cannot use them to meet the needs of these members. And we want to make sure that we are also, if we're being billed for these services, that they are providing the services set forth. And it's been helpful because we have found that there have been providers that we've had to really minimize our involvement with. So our innovation partners, we've been collaborative internally and externally with our large medical groups, externally our vendors. Internally, case management has been incredibly important. Our utilization management team and nurses at the hospital, Pop Health, QI and health information, as well as California Healthcare Foundation. Next slide. And what surprised us? Well, it surprised me because I'm an old lady who's been doing palliative care a long time. And I kind of thought we were way ahead of where we were for some of the vendors. And I think sometimes there is a confusion exactly what palliative care is and differentiating it from hospice, because many of these groups are hospice and palliative care, and it's a different skill set when we have members that are not ready for hospice or do not want it. And so we have to be very clear. And we also have found that the benefit of looking at quality has been enhanced by our member matching tool. And we find when we have everything lined up that we're very efficient and successful. So our takeaway today is that as an organization heavily focused on health equity, our program has been able to reduce health disparities, which is a huge focus that has been and is even building stronger now with the events of the last couple of years. And we're able to achieve a lot of the set forth quality outcomes, but we recognize that having a quality service, you have to define what you mean. And on top of that, it's an active process that you must work on over time. Thank you.
Terrific. We've got a few minutes left. Thank you, Dr. Stone. Thank you, Lerva. And thank you both for being so flexible. This worked out really well, despite having a little bit of technical challenges. Two quick questions, and we were answered already. Lerva, thank you for answering about the updating for the member matching tool. And you try to do that annually, but every 6 months is ideal. Another question, with respect to the patient-centered member matching tool, this comment is, I would imagine that the patient-centered member matching may also contribute to better acceptance of services. So talk a little bit about that. Has that been your experience when you do this, that enrollment and staying with that program has improved? Or Dr. Stone?
Yeah, I would say, so it's hard to pinpoint though, because as Dr. Stone mentioned, MLTSS took the program over. We had many interventions as we redesigned our program. And this was one of them that was implemented at the same time. So since we've done that, we've had a greater acceptance of the program overall, whether it was this specific thing, item or all the other interventions, it's hard to tell. But I think, just thinking of the one specific member who was so adamant about his language preference, and now we do that without asking. It's something that we've incorporated into our daily practice of assigning our referrals. So I would say it has to be a factor.
And I think if you look back on everything about acculturation of population it makes sense to have this.
Yeah, and one last question then on the quality tool. So have you had provider partners improve in response to the feedback from the audit results? So again, you talked a little bit about sharing some of this information and using that as an opportunity to educate and work with them. Talk a little bit about those responses, please, with your provider partners.
Well, we could both take this. My first, Lerva, you're welcome to jump in. I would just say, I know that we did have to release one vendor because we're not improving. And then Lerva gets to always deliver all the good news to them. So Lerva, what do you think?
I think just one thing to add is that having those conversations, we have the information to support it, and when we're having those discussions, which is really important because the providers will ask. The good providers that want to do better will ask. Well, show us and or give us more direction, and we have set that time aside, and it's because we've done this exercise on a quarterly basis that we can do that.
Fantastic. And with that, I'm going to go ahead and thank you both so very much. Again, for all of us, another set of tools. These will also be made available, of course, and we'll be sharing those after the end of the convening. I'd like to introduce our last innovation presenter, and Lena Baker is the founder and CEO of the Rose Room organizations providing hospice and palliative care. And she's done that for the last 25 years. And in fact, she was one of the youngest hospice founders in California. Lena leads with innovative concepts in healthcare service delivery with an emphasis on staff competency and patient-focused care. So with that, Lena, take it away.
Thank you, Monique. Thank you so much for inviting me to present here today. It's really an honor to present to this group and be part of this panel. So I'm learning so much and looking at all the different ways that we can improve our programs internally. So next slide, please. So a little bit about Rose Room. So Rose Room was started back in 1997. Rose Room is named in my grandmother's memory. Her name was Rosa, and she spelled her name with a Z. So we are too, Rose Room with a Z. She died in a hospital setting, and she did not have a good death experience, as we understand one to be in hospice. And so I dedicated my career, my life and passion towards serving the terminally ill and allowing our patients and families the dignity for the patients to die comfortably in their homes, surrounded by their loved ones. We serve hospice and palliative care patients at 5 of our locations throughout Southern California, and we are Joint Commission accredited both for the hospice and palliative care. So palliative care was a vision I had back 13 years ago when I originally introduced it to Northridge Medical Group, which is now Optum in San Fernando Valley. And what we found is there was a group of patients who did not quite fall under the hospice philosophy of care, and those who did not quite fall under the home health model. And so they were in this middle section that really needed the support of hospice program, but either the philosophy of hospice wasn't quite there, and or their diagnoses and disease process wasn't advanced enough to qualify. So we introduced a palliative care model over 13 years ago to Northridge Medical Group, who paid us to provide these services, and learned quite a bit as a result. And it's so exciting for me to see what advancements palliative care has done over these last decade, and where we are today, where we were back then and where we are today, and more importantly, where we're going. And so it's exciting. And currently we serve about 275 palliative care patients on service on a daily basis. And we admit anywhere from 40 to 50 new unique palliative care patients onto service on a monthly basis. And at one point, we had over 700 palliative care patients on service. And with that type of big patient population, we were able to put certain policies and procedures and protocols in place focused around quality care and outcomes. Next slide, please. So my innovation here that I'm introducing to this group is in quality care and our QAPI program. So what we learned is that it's really important to measure outcomes. We may think we're good, we may think we're doing good, but are we really doing good? And what do our numbers say? So when we put together our robust palliative care program, we not only focus on clinical outcomes, but also outcomes around marketing. And how are we doing with educating the community and our partners about palliative care? What does a palliative care patient look like? What kind of services does palliative care provide? The admissions, the growth, the conversion ratio, those are just as important, in our opinion, as the actual clinical outcomes, which are, are we measuring pain? What about the medication safety? Are we addressing the post? What about patient satisfaction after the patient's discharged from the program? So every quarter we get together with our palliative care team and determine, are these still the right measures for us to measure quarter in, quarter out? Or have we met the goals and that we set out for ourselves? And do we need to sunset some of these quality measures and replace them with others? So I will be sharing some of the statistics from our previous quarters as results and kind of walk you through what we've done with them as a quality committee. So we have a director of QAPI, and she does a lot of the tallies that she gathers from our EMR for palliative care and puts these statistics together. And then we come up with the goals. So here you could see in the column 2021 goal, these are the goals that we're trying to meet based on the different quality measures that we put in place for the program. Now, it doesn't mean that we're going to meet all of them, but when we come up with the goal, the percentage, like for example, we want no more than, I think it says 10% of our patients to die in a hospital setting. We may or may not meet that every quarter, but are we able to come close? And are we able to sustain it if we do come close? And if we are, then do we need to still keep the measure alive, but then make the goal 5%? And so these are the kind of things we look at quarter in and quarter out with our QAPI program, with our QAPI director, based on the measures we pull out of the clinical record for the palliative care patient. Next slide, please. So here are some of our results. So this one here talks about assessment. So in addition to looking at the quality measures that we feel are important in a palliative care patients, because we're Joint Commission accredited, we must also be concerned with Joint Commission standards. And one of the Joint Commission standards that we must meet is that we have the initial assessments done within 14 days of the patients being admitted. And so you can see that we've done pretty well here with 100% in the fourth quarter of 2019 and kind of stayed above our goal of 90%. So we have hardwired our systems and processes here to ensure that all the necessary disciplines are meeting and having the contact with the patient and the family to do the proper assessment so that we are compliant from a regulatory perspective, because as a licensed hospice and palliative care provider, and I should mention that we do have a separate license under SB 294 to provide palliative care services, we must also be concerned with the regulations and ensure that we are meeting the regulations. So we decided that for 2020 that we were going to look at ourselves through QAPI and ensure that we're getting out to our patients and families timely to do the proper assessments. And then of course, the real important one is, hospitalizations within 30 days of admission. Through our relationships with the health plans and payer sources, it is key that when those palliative care patients are referred to service, that we are able to manage their systems and manage them at home. So how well are we doing with that within the 30 days and ongoing? And as you can see, these are real results because we had a spike there in third quarter of 2020, where we were at 23%. So that was not a great quarter for us. And we're like, okay, what do we do with that? And so we look, and it could be a couple of outliers. Perhaps it could be a myriad of different things, but that is why we have a QAPI committee that meets quarterly and really evaluates how we're doing in meeting the goals and progressing towards these goals. And as you can see in the first quarter of 2020 and the fourth quarter of 2020, we either met, as well as the second, we either met and or came real close to meeting the goals. So as part of our QAPI committee, we're probably not going to say, oh, we're not going to look at this measure, but we're definitely going to study that third quarter and decide what happened there that we were so much higher than what we believe the realistic goal and expectation should be. Next slide, please. So another measure here is patients dying in the hospital. So with our palliative care program, we want our patients to die on hospice. Our goal is to get patients transitioned to hospice from palliative care once they meet the guidelines of hospice and they feel that hospice would now be the right modality of service for them. But regardless, whether they transition to hospice or not, we want them to die at home. And we've been very successful in achieving that goal. As you could see there in the first quarter, all the way through the fourth quarter, we actually met the goal of being under 10% or just 10% for patients dying, less than 10% dying in the hospital. So we realize and recognize that we're not going to be able to prevent every patient from dying in the hospital. But if we have less than 10% die in a hospital, then we feel that's a very good statistic for palliative care. And we also have a lot of communication and coordination with our health plans and our payer sources. And we say, well, what is a good statistic? If we can demonstrate that less than 10% of our patients die in a hospital setting, would that be a good measure for you? And so there's a lot of collaboration that's happening on the payer source and the medical group and the health plan side. So to help us understand their needs and what they're looking at so that we can continue to have those strong bonds and build those strong relationships and to administer those great palliative care support and services. And of course, patient satisfaction, right? We want to get all 9s and 10s in the satisfaction rating. And would you recommend our PC services to others? You could see there 100% on the 9 and 100% on the recommend, and then 67 on the 9 and 10, but 33% not rated. The post and placed is also really important. We're all focusing on the post and place, and it's an important tool for our families and our patients to have in place so that we know what their wishes are. And in our matrix for the post, it's did we discuss the post? It doesn't mean that we must have one in place, but did we discuss the post, and was it decline? And you could see that 65% of the time we are successful in actually having a post in place for our palliative care patients. 26% of the time we've discussed it and addressed it, but the patient family are not quite ready to put one in place. And then of course the 9% of the time, maybe we haven't had the discussion yet, or we haven't discussed it. And so we look at that and say, well, why haven't we? What was the issue? What was the outcome? And how are we progressing to meeting that goal? Next slide, please. So the key matrix, the key performance measures that we do and our challenges and the needs to be addressed is to make sure that we are looking at what are the most important factors that we feel a palliative care provider should be looking at both from our internal perspective as well as from the health plan perspective. And so patients dying in a hospital to be less than 10%, that's a key quality measure. All medical groups and health plans, when they refer a palliative care patient, their hope, as it is ours, is to transition appropriate palliative care patients to hospice, and preferably sooner rather than later, so that we can increase that length of stay on hospice, because as we all know, hospice length of stays are really short. So are we able to transition palliative care patients to hospice, appropriate palliative care patients to hospice within 30 days? And are we able to do that 15% of the time? Post in place, we want to make sure that we have a post in place and 95% of the time or greater. And then, of course, percent of patients hospitalized within 30 days of admission to be at 5% or less. And we want an overall satisfaction of our care to be at 90% and above. And what in order to achieve these goals, and in order to achieve these measures, of course, the payer sources, health plans, Medi-Cal health plans, and insurance health plans have to be aligned with the payment model. And what we're finding is that per patient per month payment model is the best to align to be able to effectively achieve these goals for quality measures and quality matrix. And to achieve the triple aim, which in our palliative care program is patient satisfaction, good clinical outcomes at a reduced cost. Next slide.
So Lena, this is Monique. Up just another minute or two. We've got just a few questions. Okay, we'll squeeze those in. Thanks.
No problem. All right. So again, utilizing the 360 quality assurance and performance improvement plan. And we want to make sure that by doing these quality measures, we're able to look at our work and the areas that we need to improve in, because quality is all about improvement and processes and process improvement. And then we also want to share this information with our plans and the performance tool. And we do that through collaboration and coordination with the different referral sources. Next slide, please. So partners, and we talked a little bit about that. So our external partners are our, physicians, the health plans, the medical groups, different discharge planners. But I have to state that our internal partners have to be bought in order for our external partners to recognize the value that we bring with our palliative care program. And our internal partners is our staff. It's our referral process. It's our medical director. It's our leaders. It's our sales and marketing team. And of course, after hours and weekends. Next slide, please. So as a result of implementing the QAPI program, we found that we thought we were good, but we also need to be better. And that's always our philosophy with Rose Room. If we think we're good, let's have the numbers show for themselves. And as good as they may be, clearly we could always do better. And how do we do that? And continuous process improvement and quality is key to any organization, especially with palliative care, as we're moving forward and trying to establish palliative care as a mainstream benefit across healthcare.
Yeah, Lena, so thank you. We have two quick questions. They're sort of falling in the bucket, so I don't mean to take away your final wonderful slide, but the one is sort of addressing some of the makeup of your goals, and the other is sort of thematically talking about the SB 294. So just with respect to SB 294, there was some interest in understanding what license you have under SB 294, and some questions about sort of for those providers participating, are they submitting to OSHPD or getting the plans? And I want to make sure I get this correct. Also, are the plans getting the data to the providers so they can submit to OSHPD? If you are able to do that in a succinct way, please share with us any information.
Of course.
Yeah.
So SB 294, the Department of Health has allowed hospices to apply for an additional license to be able to provide palliative care under SB 294. And it's a demonstration project. And as a hospice provider, you can apply for that license and therefore serve palliative care patients under your hospice and palliative care license. That's SB 294. It's been around for a couple of years now, maybe 3. As a result of that, you do have to submit on an annual basis your palliative care census as well as other reporting similar to OSHPA, but not quite OSHPA.
Okay, great. And this is the next questions are a little bit about your goals. This question is, how did you determine 15% was the goal for transfer to hospice within 30 days of admission?
So experience, it's we look at data, past data. What have we been able to achieve before? And then with always a stretch goal.
Okay.
So, mhm.
Okay, and then talk a little bit more generally and broadly about sort of choosing these targets. This is, you have your QAPI director and you have your clinical staff assisting leadership in the process of identifying new goals. A little bit about how you talked about sunsetting some and then launching others. Can you kind of maybe tell us a little bit more that inside baseball of how that really happens? It's gathering all that information, as you mentioned with the MR. Is there any other pearls you want to share about that?
Sure. So the QAPI committee consists of our QAPI director. It consists of our palliative care team leader, our regional director, VP of Ops, and our medical director. And we look at past year, quarters history and determine whether we've been able to meet the goals or not. If we were able to meet the goals and we hardwired our systems and processes, then we sunset those measures and replace with others. If we're not able to meet them, then we do more education and training of our staff.
Okay, with that, we are going to thank you and thank all of your colleagues. Just a quick note to everybody, these 4 groups of presenters worked very hard, and we would like to thank them so very much for sharing those innovations and helping us all to learn from them. Thank you, thank you. We now have a 10-minute break, and we will resume at 10:40. Thank you.